Hi, so today I'm going to be talking you through heart failure. And this is a concept which a lot of people struggle with, so I'm just going to try and make it as basic as I can. And the way that I like to talk through most diseases is using an acronym called CESPIT. Now, C stands for causes, E for epidemiology, S for symptoms, S for signs, P for pathophysiology, I for investigations, and T for treatment. And most of the videos I do which are talking about diseases will be following this vague pattern. So to start with the causes of heart failure. So there are three main causes. These are myocardial infarction, where you have dead tissue. So this means that the heart's able to pump less effectively, causing the heart failure. You have high blood pressure, and this is where there's greater resistance peripherally to your attempted pumping from the heart, so it starts to struggle because it's trying to overcome this resistance. And then you have valvular disease, and that causes problems within the heart, so the blood isn't flowing through the heart as effectively as it should be. So who does it affect? So heart failure is very common. It's similar to the rates of breast, lung, prostate, and colon cancer combined. It more commonly appears in men, but because men don't live as long with the condition, the overall prevalence within the population is fairly similar between men and women. And there are different causes of it. In developed countries, you see more hypertension causing problems, whereas in the developing countries, it's far more often related to valve diseases, which are more commonly infectious, or through things like cardiomyopathies, which are genetic. So we can classify it into 4 different levels, and this is the New York Heart Association, or NYHA, classification of heart failure. So class 1 means that there's very little limitation. You might have some palpitations, but they're rare, and some shortness of breath. Class 2 is still mild, but there's a slight limitation on your physical activity. Class 3 is where you're comfortable at rest, but when you try and undertake physical activity, you can start to struggle and get really quite short of breath. And class 4 is severe, and this is where you can't carry out any physical activity without severe discomfort. You've got palpitations and shortness of breath, even when you're resting. So you might have heard a number of different terms about heart failure and the different types. You've got systolic and diastolic, you've got preserved and reduced ejection fraction, and you've got left and right heart failure. So I'm going to try and talk through what heart failure actually is and make these terms slightly more clear in what they mean. So the ejection fraction is the proportion of blood that's present within the ventricle that's ejected with each contraction. So when you look at this, you're typically looking at the left ventricle. And say your left ventricle fills with 100 mils of blood, then when your heart contracts, if it shoots out 70 mils of blood, then there'll be 30 mils left. So that means that 70%, 70 mils out of 100 mils, has been ejected. So your ejection fraction would be 70%, and that would fall within the normal range. As the contraction of the heart gets less effective, you might start to get a reduced ejection fraction. So this would be when the heart contracts, out of that 100 mils, only 35 mils is able to be pumped out, and then you still have a significant amount of blood left in the heart. And you can see how this could lead to heart failure, because you're essentially not pumping enough blood out of the ventricles with each contraction. So, preload. What is it, what does it mean, and what is Starling's law? Well, when you fill up your ventricles, the cardiac muscle sort of stretches like an elastic band. And then this means that when your heart pumps, it's able to pump more powerfully because it's sort of stored up the energy like an elastic band as it stretches. And that's what Starling's law is showing you. As your preload is increasing along here, your stroke volume also increases because you've got more preload, so that's essentially more blood coming to the heart, and this stretches the muscle further, allowing it to pump more powerfully and pump out more blood. Now, once you reach a certain level, the heart muscle begins to become overly stretched, and that means that it's damaged and therefore stops being able to pump blood as effectively. So you can see here, you've reached a certain preload and the heart muscle is now damaged, so it's unable to pump blood as effectively and the stroke volume begins to fall again. So afterload. This is the resistance to the heart attempting to pump its blood around the body. So this is mostly made up of your systemic vascular resistance or your blood pressure. So if you have vasodilation throughout your body, then you'd have a really low blood pressure and it would be really easy for the heart to pump blood all around the body. If you had vasoconstriction, then your blood's trying to pump through these narrow arteries and arterioles, and so it becomes really difficult for the heart to pump against this pressure, so the heart might begin to tire, and we'll talk in a minute about what effect this has. So first we have our systolic heart failure. So this can be caused by an increase in our preload, which means that you have more blood coming into your ventricle. Now, as we said, this causes damage to the ventricular walls because they become overly stretched. The ventricular walls then become thin and remodeled, and when they try and contract, they can't pump as much blood out of the heart, and so you have this ejection fraction going down from the normal range down to below 40. And this is called heart failure with reduced ejection fraction, also known as systolic heart failure, because the problem is in systole, so when the heart's trying to pump, and it's unable to pump as effectively. This is also the type of heart failure you see when you have a myocardial infarction, because although there's no initial increase in preload, you do have the damage to the ventricular walls, and you sort of start at step 2. You have the damaged walls, which become thin and remodeled, and you can't pump blood as effectively because the tissue around it has died. So we also have diastolic heart failure. So this is where you have an increased afterload. So this is, for example, in patients who have hypertension. This causes the muscle to try and work really hard to overcome this resistance caused by the high blood pressure. And that means that the cardiac muscle is working really hard, so it starts to hypertrophy and thicken. But then because the cardiac walls thicken, they grow both inwards and outwards. So as they grow inwards, they make less and less space present within this ventricle. This means that when blood comes into the ventricle, less blood is able to fill it up. So rather than the previous 100 mils that was coming into our ventricle, we've now only got 50 mils within our ventricle. When the heart pumps, it's still able to pump out fairly effectively because it's now this thickened wall. But previously we were pumping out 70 mils, whereas now we're still pumping out the same proportion, but now we're only pumping out 35 mils because there's only 50 mils present. So you're still pumping out 70%. So the ejection fraction is the same. And when you look on your echo, it might look like the same amount of blood is being pumped around the body, but in reality, there's much less blood being pumped because there's less blood filling these ventricles. So you have a reduced cardiac output, and this is called diastolic heart failure, or heart failure with maintained ejection fraction. So you also have left and right heart failure, and that quite simply is talking about which side of the heart is affected by the heart failure. So if you have left heart failure, then it means that your left ventricle is pumping less blood around the body, either due to systolic or diastolic dysfunction. So this means for a start, you've got less blood being pumped to your tissues, So you've got less activity tolerance because you're not getting enough oxygen to your tissues. And it also means that because the blood's trying to flow into your heart, but it's not pumping enough blood out of it, or it's become overly enlarged, you start to get congestion, which is where the blood backs up into your pulmonary veins, which are coming into the left side of your heart, and then that also backs up into your lungs. And this causes pulmonary congestion. Now, this can cause two things. It can cause impaired gas exchange, and that means that you'll start to see signs of cyanosis, so that's bluing and hypoxia. And it means that you'll start to get edema, which is fluid around your alveoli. And so you'll get people coughing, you'll get paroxysmal nocturnal dyspnea, which is where they start to get severe coughing when they're lying down at night in particular, you'll notice that. You also have right-sided heart failure. So this is where the right side of the heart is damaged. And this means that your congestion isn't going to go to your pulmonary veins, it's going to go to your SVC and your IVC. And so you'll get congestion of your peripheral tissues. So this is where you get edema, so you can get swelling of the ankles, you can get ascites, and that's sacral edema. And you can also have things like liver problems due to the congestion in the portal system, and you can get congestion in your GI tract, meaning that you'll get anorexia and weight loss. So how do you work out whether or not a patient has heart failure? Well, you'll have a look at a couple of key things. One of the things you'll look at is your blood results, and you particularly want to have a look at the urea and electrolytes because blood pressure is closely related to your kidney function. So you want to ensure that the kidneys are working effectively. You also want to have a look at B-type natriuretic peptide, also known as brain natriuretic peptide. And this is released by the cardiac muscle when the ventricles become stretched. So if you've got too much stretching of these ventricles, as we've said happens in our systolic dysfunction, then you'll see a very high level of B-type natriuretic peptide, or BNP. So that's a good way of determining, if you see that you have heart failure, whether or not it's systolic or diastolic. You can also do that through imaging by using echocardiography. And this is where you use an echo to determine what the ejection fraction of the heart is. And if the ejection fraction is preserved or reduced, then you can work out which type of heart failure you're looking at. Also, when you do a chest X-ray, there are a few key signs that you can look out for. So you can have hypertrophy of the heart. So this is where you'll start to see the heart being enlarged, and on a PA X-ray, if it's over 50% of the width of the chest, then you can tell that the heart is enlarged. Or you can look for curly B lines, and these are small horizontal lines which are present often in the lower part of the lungs, and they signal that there's pulmonary edema present. So you normally treat this through various different medications, which are essentially trying to lower the blood pressure and make it easier for the heart to pump. You use beta blockers because that's to slow the heart rate and make sure it's not working too hard. And you use diuretics, and you normally will use loop diuretics or thiazide-like diuretics in order to try and remove some fluid. So this is particularly for treatment of edema. So in summary, that's heart failure. I hope that was helpful, and thank you for listening.